Generally, you're looking at a year and a half to maybe 2 years in that range of considering when it's time to jump on it. But once again, you kind of want to have your body equilibrated and reach the point that you're really hoping to be. You know, it's a multi-stage treatment, and as I pretty much tell people, you didn't gain all your weight in a year, you didn't lose it in a year, and you're not going to get all your contouring in one day either, because a lot of these are very complex operations that, for me, depending on the body mass index, the degree of skin excess, how it's distributed, because everyone's kind of unique in how they lose weight and how they held on to weight. And so some of these operations are 8.5, 9 hours. I don't want it to exceed that, because one, I can't handle it, and it's not good for you either. So you may or may only get one or like a torso or breast, but you're not going to get like arms, legs, and breasts. You just can't do that. It's too much work. It's too complicated. And so it's not a one-shot deal. I'm getting it all done in one day. So just go in with that mindset. And then, you know, you do need to know that, you know, no plastic surgery for post-bariatric treatment is covered by insurance, because there's just no codes that would adequately reimburse us for spending 8.5, 9 hours on a day. Because these codes are like paniculectomy, and they view it, we can do something like that in an hour and a half, and that's just not the case. So it's just, it's fee for service, so you just have to figure out about that. But the good news is, it's well documented in the literature that people who do undergo body contouring plastic surgery after bariatric surgery weight loss are way more likely to maintain their weight and to be good stewards of their body and to preserve what they've worked for. So, you know, it is worth doing it in the end. And also, if you've lost a tremendous amount of weight and you're stuffing your skin inside clothing to make it feel less conspicuous, you know, a lot of times you can't appreciate all the work you've already done. And once you get rid of that hanging tissue and get things lifted and put where you want it, all of a sudden you kind of see what you've worked hard for, and you're no longer a prisoner in your skin. So it really is a nice thing to kind of do as a reward to yourself, and also to be able to give you some positive reinforcement in all the hard work you guys have done. You all know, if you've been in this post-op care, that it's hard to get some protein down. It's not simple, but I honestly want, at a minimum, particularly if we're doing a circumferential lower body lift with thigh-plasty, monsplasty, the whole works, it's a lot of healing from here circumferentially. So we're wanting you to get probably in the neighborhood of 80 to 90 grams of protein in it a day. So that's not simple. So, you know, if you're just sipping on a little straw for protein shakes a couple times a day, that's not going to cut it to really be able to heal well. So you do need that good nutrition. And then the other one, and I have to kind of fight with some primary care people if they don't have, fortunately, if you're at this kind of a center, particularly, and you're still connected, you know, looking at someone's hemoglobin or hematocrit, that is only one component that tells you what your iron levels are. You can have a completely normal blood count, but if you dig deeper and you look at your total iron stores, you can be very low. And, you know, a big operation, you don't lose a lot of blood, you lose some, and then you're going to have to build it up, and that depletes you of some iron, just building that iron, those red cells back up. So you're dealing with a state that I always, you know, not everyone's the case. And people who have sleeves, most of them don't typically have iron deficiencies. The Roux-en-Y's are a little more, and then there are the pancreatic diversion duodenal switches are even more. But the big thing is, we do want to make sure your iron levels are good, and in most cases, if there's rewiring and you don't absorb iron quite well, just pouring a bunch of pills of iron ain't gonna cut it. So sometimes we need to actually reserve about 4 weeks just before surgery, and we're giving iron infusions once a week for about 4 weeks to really get you up to snuff. Primary care doctors don't understand that, but you know, what I don't want you to do is end up with wounds, and it can happen. So we want to do everything we can control to minimize this, because we do a lot of things and we're trying to minimize complications. So, and then the other thing is, you know, it's a whole body experience, right? We're all, you know, sound body, mind, and spirit. And if, you know, if you have any mood disorders, bipolar, things that, you know, if you add a stressor like surgery, could that make things difficult? So just want to make sure you're kind of optimized, that you're feeling good and your mood's okay, because surgery is not a minor thing. It's an abdominoplasty with its core fascial repair. It's not uncomfortable. It is uncomfortable for a while. We'll get you through it, but you know, once again, you just got to be prepared for it. And then the other thing to consider, in our literature, it says up to 40% of people that do seek post-bariatric body contouring have some degree of what's called body dysmorphic syndrome. And that's kind of where, you know, just deep down, you're not happy with who you are, how you look, and that can temper kind of how you would view your self as an individual and how you view yourself going through the surgeries and what your outcome is. So these are all things to kind of think about and make sure they're optimized before you decide to have surgery. So those are just some things that I've kind of looked at over the years. I've been doing this for about 24 years. So, you know, there's no hard and fast rules. I have to say, when I was marching along in the early 2000s, I was a little more dogmatic about it. Like, first operation needs to be sort of that keystone area, the abdomen. But you know, everyone has different perceptions of what they're not happy with. Some people maybe didn't like their arms their whole life. You had the weight gain that made them uncomfortable. Then you superimpose maybe 150-pound weight loss, and all of a sudden they've got bat wings and they're not happy with things. So, you know, if someone's arms are a problem, I've done several people as the very first operation, their arms. Now, I wouldn't do the legs without doing the belly, because if you don't correct that overhang first, the anchoring becomes more difficult for doing the legs. And, you know, yes, at some university settings where they got like 4 surgeons all operating at one time, but in general, I never do legs and a body lift at the same time. It's just, it's too much. So, so we kind of, you know, it's part of the initial consultation is to kind of get an idea of what's bothering you, what are the things that are of concern, so we can kind of come up with it. But I would say the vast majority of people that come to me, their first operation is some form of abdominal rejuvenation, with or without also adding the flank area. And yeah, the other little point is that it's not cookie cutter. Everyone has very different body habituses. Everyone has different levels of skin redundancy. Everyone has different body mass indexes. And so you have to temper things and choose how you're going to proceed. So, you know, this is not an uncommon person that walks into my office for a consultation. She's had about 200-pound weight loss. There's quite a bit of skin excess. And the other thing is, in choosing what operation that we do on the belly, is where is the redundancy? You know, is it horizontally and vertically, or is it just mostly vertically? And then is it mostly confined to just the front? There are people who have lost a tremendous amount of weight, and this back area never bothered them. There's not a lot of excess, and we can leave that area alone. But there are others that have beginning to have the lateral thigh really droop down. The whole this whole area is redundant. The whole posterior flank is really over contoured, and so those are where you start looking at more of a 3-dimensional concern. And then once again, maybe you have to still stage it depending on their size and their weight and overall health. So kind of talked about that, you know, and once again, God made us very unique, and we all present with different issues. You know, the far right one, I would say, has a fair amount of fatty layers underneath the skin, and as well as some skin excess. The second to the right one is a more deflated look, but she was blessed with very good skin quality. The dermis was reasonable, so that even though she lost a significant amount of weight, she does not have an overabundance of skin excess, because her dermis just was stable. It's just like some women who have had 2 or 3 babies and their bellies still look pristine, and others, they're 18 years old and they haven't even had children, and their abdominal wall laxity, skin stretched. So everyone kind of presents with very unique structures before and also after weight loss surgery. This one we already kind of talked about. This one's still a little bit overweight, more skin draping, a little more pubis descent. You begin to see that lateral hip laxity that we start talking about. So there's not one cookie cutter operation for everybody. This was an example of a woman that had lost, she lost almost 150 pounds. She had a pancreatic diversion duodenal switch, which for all you guys have probably been in this learning process and so forth, that's one of the more extreme versions of restricting calorie consumption. And in fact, when I saw her the first time, I'm like, she was on a GLP also, after having lost plenty of weight. And I'm like, you got to get off that. I need you to gain a little weight. You've overshot, and you're just not going to heal as well. So we had her go off the GLP, got her to gain about 10 or 15 pounds, and then that was her preoperative, and you know, mostly a vertical laxity. Hips aren't too bad. Mons pubis is descended, and mostly when you're looking at it from the side, it's what we call a scaphoid abdomen. This is all related to a weak abdominal wall, which just allows all the tissue to fall forward. And you know, liposuction, skin removal only would do nothing for this person. She needed a significant abdominal wall repair, and that's what hurts in doing these operations. So that's her before and after. I don't know why it's so much darker today, so you know, we corrected the pubis, got rid of the vertical skin excess. I tend to make more of a vertically oriented umbilical area, belly button. We do kind of a high lateral lift. And then from the side, you see what the difference. Yes, I took skin out. Yes, actually I did 0 liposuction because she had very little fat. But her abdominal wall needed to be repaired, and that made, you know, a huge difference for her. So, like I said, everybody comes different. This person, as we mentioned, you know, has still a higher BMI, probably mid upper 30s, had some skin excess, but contained a lot of fat. This person had never had children, and but still had some ab wall issues. So you know, you can see the before and after with some pubic lift and recontouring, kind of shaping the sides. You can see we got rid of that kind of pannus. We got rid of the bulge through the abdominal wall repair, and we also did some back liposuction as a staged procedure, actually, because her tummy tuck was enough for her. This one is the one that, you know, not as much of a weight loss, didn't need as much, and then her skin quality was fairly good, although you can see these stretch marks that did become a little more evident. But you know, the closer you are to an ideal body mass index, the better your outcome's going to be. Now, we also did her breast simultaneously, because the key is nothing was so complicated at one time to work with. So my combined operation was about 8.5 hours. So I was able to do the breast and the belly. But a lot of post-bariatric breasts are very challenging. So a lot of times that's enough of an operation by itself. We'll talk about later. So, and then, like I said, this is, you know, an example, and I'll show you her picture, but this person had horizontal laxity as well as vertical and required what's called a fleur-de-lis pattern. You know, it's kind of like the French flower, the fleur-de-lis. And that's because we're taking out 2 vectors of resecting. So who needs the fleur-de-lis? It's becoming a larger and larger number that I'm actually doing. And it's particularly for people that only need to address the front side if the back side's not really a problem. And in removal of skin, you're doing 2 vectors of tightening. You're along the vertical axis, horizontal tightening, along the horizontal axis, vertical tightening. And so you can get rid of a fair amount of skin at a time. Now it does increase the risk of some wound complications because of blood supply, but you know, that's kind of showing you what we're doing. And so we're taking a you know, a swath out this way, and you can see it gets it tighter. Yes, you have a little vertical scar, but it also helps pull in from the sides without needing to go all the way around. And sometimes we'll do it as a stage thing if we're not sort of on the edge of do we need to do it, because that vertical scar is the same length as almost the transverse scar. So it definitely bumps it up by an hour and a half or so more than a traditional abdominoplasty. So, you know, the circumferential body lift, I do a fair number of them, but it's also, you got to match some requirements. If your BMI is real high, I will do them in 2 stages. If you have some anemias and we don't want to get too much blood loss, we'll probably do it in stages. If you know, if you got some medical comorbidities, diabetes, some other things, probably would stage it in 2 steps. But you know, there are a number that we can do all circumferentially simultaneously. But it's a big operation, but it's addressing lateral thighs, the pelvis, the ab wall, the posterior flanks, kind of the gluteal area. So it's a big operation, but it hits many things. And for the circumferentials, I typically bring you in the day before. I mark you for about an hour and a half because it's a little tiring to do all this marking and then start an 8-hour or 9-hour case. So I mark you the day before. We determine how much tissue we're removing. You're kind of seeing how much tissue is being removed all the way around. Lipocontouring, superior lift of the lateral thighs. This green hash mark is where we actually take the outer skin out, leave the fat behind. We can either purse it up or rotate it down a little bit to prevent, particularly on a female, of getting too, as you elevate it superiorly, not to make it so flat and be or masculinized. So you can kind of see these pictures all the way around. That's her afterwards. Yeah, she had a few little scar things, which we can touch up later. And oftentimes, if the transverse width of the pubis, and particularly with all the athleisure wear, everyone wants to look sleek down there. So we'll take out a vertical wedge here as well as lifting it. But you can see that it can, you know, lead to a much flatter thing. Now, I point this out. This area is typically addressed with the arms. So we do a removal all the way down like this, because you can only do so much up in this area, because this is not just lipocontouring. This requires skin removal. And like I said, this was already a big enough operation as it is. This was the first one I did in '02 of a circumferential body lift, and it achieved results that I was happy with. But you know, in my training years in the '90s, no one was doing any pubic resuspension and recontouring, so we didn't do anything here, and it still looks bulky, and it's just, once again, some of the evolution of techniques over 20 years and what we kind of focus in on. And then you can see your pre-op, post-op results, but you can see it got rid of quite a bit of this even without doing anything in the upper, just by the way we were able to reposition some tissue. Another lady that had lost a fair amount of weight, but not a lot of skin excess, but everything was just kind of falling down a little bit, and that's once again the markings that we do. And you can see that, you know, we were able to give her more of an hourglass, also lifted the pubis up, and you know, one of the things I learned over the years also is hair-bearing skin doesn't do as well with quick healing because the hair follicles can disrupt things, make scars get a little wider. So I use a little permanent stitch that I take out in 2 weeks, and that generally leads to a better looking scar. And I also use this woman to show, yes, wounds can occur, and that has to be, it will heal, and then we can do a touch-up, but full disclosure, sometimes with tensions and blood supply and everything, you can get a little bit of breakdown, but you know, that generally can heal in a few weeks. I just wanted to show that. This was a girl that was pretty young, had lost a fair amount of weight, and once again, not major distortions of skin excess and a lot of things. And that was her markings for the circumferential. And once again, took out that wedge there. And you know, you can see that we've improved the hip, improved the buttock shape a little bit by doing a little bit of lifting with that, and gave her a better looking result. So, you know, and that's another woman who's a little bit older. She was in her 60s, had weight loss, and so, you know, once again, what kind of laxity of skin you have can impact what your end results are like. But, you know, you can see that it can make a nice difference. This was a guy, actually. He had one of those lap bands, you know, it's kind of like a balloon you put in the belly and to occupy space. Well, actually, I take that back. It's got a little, almost like a sleeve that is water filled, and you had a port. So we actually took his port and moved it down. But he, you know, people can cheat with that one, and you can, and I don't think many people are doing that operation as much today, because you can cheat. But that just shows you his body lift markings before and after. So I mean, those are pretty helpful. So you know, like I said, what are the, you know, for staging, we do consider, because like someone like that, we actually did sort of a modified paniculectomy. She was a woman that had recent diagnosis of MS. She had a lot of tissue. She had not undergone bariatric surgery. She was heavy. She was worried about her mobility, and so we basically took off some tissue and tried to unburden her. But once again, dealing with a breast like this is not, that's not 5-minute operation. It's a lot of work to get that where it is. And you know, I'm just showing you, like, so that's a marking, and so why we would oftentimes say, where are you going to end on this? And it's why you need the circumferential sometimes. It's another one that had a circumferential, but she had a stage thing. She had actually had a little paniculectomy, I think by the bariatric surgeon when they used to do them. They don't touch them anymore. But you can see we can able to give them some improvement. And then, you know, yes, when you got a young girl, this is an example of a lady that had a couple kids, gained and lost a little bit of weight, still had maybe a little troubling stuff with ab wall. We were able to do it all at one time, because the distortion is not that bad. And this woman had a abdominoplasty by somebody else. You can see how much it left behind, all that lateral redundancy falling down on her lateral hip, and we had to do some modification because of the way they had the original design on that scar, and able to get some good hip lift with that, you know, and blend the gluteal and the thigh area. This also shows you example of someone that we did a staged operation also with breast lift and arms and a lateral chest. Because also, yes, she had implants before. They had deflated or they had stretched and fallen, had redundancy, but nothing was too complicated that allowed us to do a couple things at one time, but not with that flankplasty. That's separate. And then kind of seeing from before, after, what you can do with that thigh. So, you know, like I said, everyone comes to the table with different things. When you have a breast like this, it's not, you know, yeah, you may not have much volume, but you got to do a lift first before I would even touch adding an implant. So I have to say, with over time, if someone has some reasonable breast volume, because the post-bariatric breast, the ligaments that support the breast down here are weak. And if we can avoid an implant, it helps, because we're not worrying about things stretching so much here, because an implant has weight. It does. And now, yes, there are meshes that we can put in. They're a resorbable mesh that can act as an internal hammock. I'll show you. But I'll tell you, the cost of the implant is not inexpensive. The cost of the mesh is even more expensive than the implants. So there's got to be a real good reason that I'm going to step you up to a mesh with an implant. And if I can avoid the implant on someone and just accept a lifted, maybe a little flatter looking breast, because, you know, and once again, everyone comes to the table with different kinds of tissue. But there are a number of them that are just really weak tissue, and holding an implant's difficult. And these are kind of examples of how we put these meshes. There are actually porcine derived, meaning pig derived, because their pig dermis is much thicker and sturdier than human derived cellular tissue. But you know, these things are not inexpensive, and like I said, they act as hammocks. They can hold implants up, and you know, it can be very helpful for the right person. But once again, you're stepping up prices. This was a young girl that had bottomed out with implants, and she didn't want to go down. Generally, I would downsize people. She didn't want that, so we added a mesh, and you can see that now the fold and the breast are ending together, as opposed to everything falling down onto the abdomen. You know, it's another example. You've seen this other lady before. So this was a way deflated, stretched skin that fell down, so the implant's laying on her belly. This is now that it's lifted up with the lift at the same time. And it's kind of showing inside where we're creating meshes to support that as we're closing it all down. Another lady that had implants elsewhere, lots of laxity, stretch, fall, and she wanted bigger implants, which, you know, I'm not a huge fan of very large implants, but that's a lift with some mesh and a new implant. This is a woman that, you know, this kind of thing I see with people where their scar pockets aren't very sturdy, they stretch, and everything just fell down on her belly, and she came to me for a revision, and I downsized her implant actually quite a bit, almost 100 cc's, which is about a cup size, but yet the projection has been maintained. You don't see it hanging on the belly anymore, and we were able to do some things with electrocautery, kind of shrinking the collagen of the scar pocket, doing some suture fixations, and you know, we try to do some things without adding that mesh if we can, and she's been able to preserve her shape pretty well for a couple years now. You know, these are kind of examples of just the markings. Yeah, and that's another example. So, you know, basically the way I look at things, if your nipple position is well below the inframammary fold, I'm going to stage you. I'm going to do a lift first, get everything in position, then we can come back and put an implant in. And that's what we did. So this was actually 2 steps to get to that point, because repositioning that nipple and removing skin, tightening while simultaneously enhancing volume internally, they're 2 competing operations. So if the nipple's just slightly down or just above the fold, we can do that pretty safely, and I'm fairly bold on that. But you know, if that nipple position is well below the fold, it's got to be done in a 2-step process. So now this is an example of someone that all we did was a lift. We were able to reposition her tissue, and a lot of times when people have a fair amount of volume to work with, things are hanging over the belly, we can actually take a little flap of tissue that is hanging like this. We take the outer skin off. It's a flap of gland tissue, and we can tunnel it up underneath the muscle, and it's sort of like an auto enhancement. So it can give you a little more volume without adding an implant. I mean, it's not as exaggerated as an implant, but it gives, I think, a much reasonable shape without adding the cost of the implant and the other things. So that's another example of a reduction lift with this auto enhancement by de-epithelializing this little pocket and flipping it up under the muscle. So, and then that's, you know, kind of the classic scar, goes around the areola, it's a vertical scar, and then into the fold. And then we typically clean up the axilla, particularly on people with big weight loss. We're taking out a big swath all the way out. You know, another one that had poor elasticity, nipple was way, way low, and so we shrunk the tissue. We didn't add any implant, and you can see it gave some reasonable shape. So, you know, it can be good. So, you know, once again, all people come in various shapes, sizes, and skin envelopes. I actually didn't operate on this one, but you can see how much skin excess that she presents, and that I would not touch her breast at the same time for me. So, and these are examples of that lateral chest wall and arm tightening procedure. You know, we take out a ellipse all the way down. We do a little zigzag here so that it's not a straight line scar. But, you know, it can make a nice difference in the overall contour. And once again, with that vertical scar, most people aren't doing this all the time. And from the front and from the back, you generally don't see that scar, because there are some people that choose a scar that's like right here. I put it kind of in this posterior inner line angle, which hides the scar better. Yeah, that's an example of the scar. And I will say bell curve on the scar in the upper arm has probably one of the wider bell curves, meaning that you know, how tight a control we are. And it really boils down to some people's dermis in the upper inner thigh and the inner arm. Some people have really thin tissues, so then it doesn't hold the deep stitches as well, so you're more likely to get a little wider scar. But that's about as good as you're going to get for a inner arm lift kind of scar. You can kind of see her before and after. Another one. Yeah, and this one, overall pretty good. There was a little dip here. I offered to fix it, and she didn't want to do anything. But you can see that makes a nice difference for before and after. And that's her scar, how it kind of comes down, a little zigzag, and goes down. Sometimes I've gone all the way down to the hip to get rid of that transverse redundancy. So examples like that. And yeah, this person, I showed her a picture before, but she did her arms, lateral chest, abdomen, you know, you can see before and after, and the breast lift, and with that mesh and og. So some of the newer things that I've been doing in the last year is drainless techniques. You can do a drainless abdominoplasty, but your BMI has to be under about 28. If you're above 30, I'm not going to do a drainless procedure. You get a drain. But even with bigger arms, I can do drainless techniques for the arms and inner thighs. We're able to close that dead space down pretty well, so you can avoid a drain. And that's kind of showing you that scar. So it's off. I rarely end here, because most people have redundancy here that rolls over bras. And even if you take this down a little ways, it pays dividends, and you don't see the bulge right here. That smooths that out a whole lot. This was, once again, one of my first people that I did back in like '02. A lot of things have changed, but we did a breast lift on her and did her arms all simultaneously. I was younger and less stupid, or more stupid probably. So, but we, you know, got things put together reasonably well. I mean, it's not perfect. I'd reshape the breast a little bit better. Another thing we deal with is gynecomastias. I have some guys I need to get on here, but you know, this is like bread and butter gynecomastia. This guy was normal young guy, had too much gland, kind of feminized looking breast, and he wanted to do this. And we can do that without removing any skin to make an incision in the nipple, one stab hole on the side. We do a lipo contouring, and then that frees up the outer skin, leaves the gland behind, then we go back through the nipple and we can remove all that gland. Now, that doesn't work for post-bariatric people because they got too much skin. And you know, even a guy like this, he had, you know, kind of a feminized breast, kind of a little bit of skin excess. We were able to get him better, but still no scar. But, you know, someone like that has real hanging loose skin, and you take out gland, the skin begins to hang, and there are people that hang so much more. And it cascades in the armpit. We're taking the scar out and then going out, and these are free nipple grafts. So, you know, it can make a nice difference, but, you know, that's a much bigger operation than the other. This is something I do employ, not that often, but, you know, I showed you that she was one that I did in '02. She came back like 25 or 20 years later, shows you how old I am, and what she wanted was a little more volume in the breast, improve that stretch that had begun to occur, and what we were able to do is make incisions in the fold all the way around, undermine the tissue pretty far down, still preserve some of these blood supply, even though she'd had an abdominoplasty before, then superiorly reposition. Instead of throwing that tissue away, we can de-epithelialize it, and you know, it can come up with an extra 100, 150 cc's of volume to tuck up underneath the breast. Yes, it does buy you a transverse sternal scar, which sometimes it can look pretty good. It could sometimes get a little wider like that, and it also, see how much it pulled up the belly without, because her excess skin was not down below like what you would need with a regular abdominoplasty. It was up here, and you see how it sleeked it up. And then I was finally able to get some redemption, and I fixed her pubis as well to make that look a little better. Another thing we do a fair amount of is thigh-plasties. It's a big operation, not nearly as uncomfortable as an abdominoplasty, nor are the arms, because we're not dealing with your core strength, core muscle fascia like you are with an abdominoplasty. And so it's a little sore to get up and down, but once again, there's no muscle fascia involved, so it's not particularly uncomfortable. That's kind of the scar patterns that we're getting rid of. You can see her before and after. You can see that scar. Sometimes we have to cross down to the knee, and just like on arms, sometimes I've gone all the way to the wrist on some people to take out skin excess. With someone that was a new drainless technique, she had not had an abdomen. That's why I hesitate to do people's thighs without doing their belly. But yeah, that's kind of the scar pattern. You see that. Improve that knee area. This was challenging to get that not overhanging quite as much, but the vector of tightening is all horizontal along this vertical axis, and then it curves up like this, and we bring up and lift the skin there, and her underwear is kind of pulled way up. That's not how she'd probably wear it normally, but you can see you get rid of some redundancy. Yes, there's some scar there, but it's pretty early on. This was only a couple months out. So it's still kind of pink and immature, and with time it will lose. But you know, I was pretty pleased that we were able to debulk this area, because that's a hard area. So, and I see from behind as well. So one last thing, faces. Done a fair number of women that after losing a lot of weight, they, you know, the fat in our face is not a sea of fat, it's in discrete packets. And there are certain fat pads that go away early in life, even in the late 30s, early 40s. And as you lose that, it gives you sort of this aged appearance. You superimpose a 100-pound weight loss, that's going to make that deflation of that mid-face cheek volume that much more. So, you know, a lot of people will then go for, and this was a younger woman, but she lost like 80 pounds with a sleeve. And, you know, she did not like the real deflated mid-cheek area. She didn't like some of the downward turning of her mouth. She felt like, even though she was late 30s, that she felt like she looked older than stated age. And so this was some restoring fat volume. Even people that have had a lot of weight loss and don't have a lot of fat elsewhere, generally inner thigh, particularly if you haven't done the inner thigh, you can harvest a little bit of fat to restore some volumes here around the mouth and the pre-cheek area right here, or pre-jawline area. That's her before, after, you know, more sculpted lateral jaw line. The scar goes here around the ear and then into the line there. So hides pretty well. You see there's more cheek volume definition, but it's a natural look. So yes, some of you maybe want to do that as well, but you know, another example of someone that had a fair amount of weight loss and some age-related thinning of skin, deflation, and hanging, and that's a neck and facelift. So that's kind of a very fast overview.